Keen observers among you will notice that we don't have an actual fire, but we do have an actual Richard. So 1 out of 2 is not bad. Richard is a former politician, Victorian senator and leader of the Australian Greens from 2015 to 2020. He also served as the inaugural chair of the Healthcare Practitioner Patient Advisory Council, and before entering Parliament was a GP and public health specialist working in Aboriginal health, HIV prevention and the drug and alcohol sector. So please welcome Richard.
Thanks, Martin.
Just quickly, for those I haven't met, I'm Martin Lane from Cannabis, and I'll be asking the questions this afternoon. But, you know, it's your conference. We want it to be as interactive as possible. So if you must chip in via the app, you may. But I can't really read it, and I'm a big fan of old school, so I want to see some hands and some questions. We've got 2 roving mics. Let's try and get the energy up a little bit. Let's introduce ourselves, meet each other before drinks. So you can use the app. Can't guarantee I can read your question. I'll definitely come to you if you put your hand up. Okay, let's get going. I've kind of sort of broadly got 4 areas I'd like to cover, being kind of GPs, politicians, industry regulation and kind of industry reputation, if you like, but you know, we can go wherever you guys want to go. If I can just start with GPs though, typically the reasons GPs cite for not prescribing medicinal cannabis are in no particular order: lack of evidence, cost and red tape. They don't always mention a lack of training on their part, of course, but what do you think we should tackle first from an access point of view?
Good question, Martin, and again, thanks for the opportunity to contribute to the conference today. I think education is a central challenge for the industry. I reflect back, I'm, 52 now. The sum total of my training around cannabis as a 52-year-old medical graduate was stay away from it because smoking's bad for you and you might end up with schizophrenia. That was pretty much the sum total of my training. We didn't even know there was such a thing as an endocannabinoid system, just a big black hole in our knowledge. So I think it's really, it's just critical that we focus on educating GPs and health professionals. You need to do that in a way where I think GPs are often suspicious of industry training. So one of the things I've really focused on and did focus on in my previous role was trying to encourage a College of General Practice to be able to provide that training and to do it in a way where GPs felt like they were getting clear, unbiased education, skills development, professional development in an area they just didn't know much about. And so I think that's really one of the central challenges that as a profession we've got to deal with.
And in terms of, you know, if you don't mind me saying, we're a way on from that now. What would you say the percentage was if you had to characterise it? You know, you've got your kind of advocates, you've got your persuadables, and then you've got the kind of never talk to me about this. Have you got a sense of what the size of the opportunity is in the middle at the moment?
I think there's a massive group in the middle who just don't know, and it's all a bit too hard. And there's a bit of red tape. I'm not really sure, does this stuff work? Again, the sort of training in the back of their mind, but still open to it. I think you've got a small group of people who are, advocates. Sometimes that advocacy can move from advocacy to zealotry, and you've got to be careful about that as well. But I think we've got some really powerful and strong advocates. And then on the other end of the extreme, you've got people who just won't countenance it and who are completely opposed to any change in this area. And that does strike me as passing as strange, because you'd think a profession in which evidence and objectivity were central would mean that you keep an open mind on it. But having said that, massive group in the middle who just want to get more information and what they consider to be objective, evidence-based learning around it. It's probably generational. So if you've got my vintage and older, you're less likely to be a prescriber, and I suspect the industry might have some numbers on this, but if you're younger, you're more likely to. Exceptions to all that, you'll get some older prescribers and some younger people who won't do it, but I think it's largely generational, and it's just a function of how much we've learnt about cannabis over recent years.
I want to sort of unpack that point you made a little bit about, things tipping over into zealotry, and you talk about cultural changes that are required within the GP community. Do you think the people in this room can kind of play a role in that in terms of the way we talk to medical professionals about this medicine?
I think so, and I think everything's just got to be. It's really like there's never ever one simple solution to what is a complex issue. Like, how do we translate the growing body of evidence around medicinal cannabis into access for patients? So there's lots of different facets to it. I think the industry's clearly got a role. It's got a role in different ways. I think the most important thing the industry can do is hold itself to a particularly high standard, and probably a higher standard than many other drugs, because there's so much suspicion, I think, from older politicians and older doctors that any sort of negativity based on what might be questionable practices has a bigger impact in this area than an area where there's where a particular practice is entrenched within the community. I think it's important that we're working with the professional bodies and offering as much assistance as we can. I know the college, as a set of general practice, and I've worked with them on trying to establish a training program. I'm hoping we're making progress there. Might be an opportunity for industry to offer some support, and at the very least, ensure that some of the expert voices that you're working with are represented as part of the training. So I think there's some things that we can do.
So would you see those medical associations as allies? They're not the enemy. I mean, we know there are some that are less positive than others.
Look, whether you like it or not, they're powerful and important, and politicians listen to them. So whether it's the AMA or the College of General Practice, the bottom line is they're going to listen to... One of the things I learnt in politics was when you go from wearing a white coat and a stethoscope to being a politician, you go from being one of the most respected people in the world to one of the least respected.
You want to be a journalist, mate.
Or a journalist. or a journalist. So, professional bodies like the AMA and the College of General Practice and other medical colleges are very powerful voices in Canberra. They are very influential, and so it's very important to engage with them and to ensure that we're doing everything we can to make sure they're making judgments based on evidence and being objective, rather than, they're still imperfect institutions. They might have a few people on the various committees who have a bias against medicinal cannabis, and the job of, I think, industry is to ensure that they've got access to the best available evidence, because they matter, they're important.
Okay, that's an absolutely brilliant segue, so thank you for that. Wearing your politician's hat, former politician's hat, what is the best way for the industry to persuade MPs of the benefits of medicinal cannabis? Is it the public health case? Is it the economic case?
I think it's a bit of everything, and I also think it depends on who your audience is. So, if you're talking to a politician who's got an interest in health, or a health minister, then health's going to be the critical argument on which you focus. If you're talking to, I don't know, the small business opposition minister opposition leader from the, I should say, shadow minister, for small business from the Liberal Party, then you make the economic argument.
Do you think it is as simple, well, not as simple as that, I know you didn't say that, I was putting words into your mouth, but is it kind of the left, it's health, the right, it's economics, or is it more complex?
It's never as simple as that, in the same way as, older GPs don't prescribe and young ones do, but it's, I think, a reasonable generalisation. I know, for example, with National Party MPs, one of the biggest arguments for them was the agriculture argument, and the potential to grow agriculture. And you can see it, because you'll be having a conversation with, for example, a National Party MP, and their eyes light up when you start talking about the potential opportunities in agriculture. So there very much is a case of, you've got to pick your audience and work out what argument you think is going to resonate most strongly with them. If you're talking to me, I'm someone like me, I'm already on side, but someone like me with a health background, then it's got to be, the thing you're fighting with someone like me, my colleagues, is where's the evidence? Does this work? Show me how it works. And I suppose the other thing I'd probably say about advocacy is sometimes advocacy is done best not through people who... You walk in the door as an industry leader, you know, automatically, if I'm sitting there as a politician, I know you've got a vested interest in this outcome, usually a financial vested interest, not always, but usually. I know when a patient walks in the door, a patient advocate... Well, I'm just looking at Lucy Haslam. My entry into medicinal cannabis as a GP who knew, you know, bugger all about medicinal cannabis, to be frank, but enough to know that some of the patients I'd previously engaged with were using it illicitly. My entry was with Lucy and her story, and she's an incredible advocate. Learning a bit more about her situation, her beautiful son Dan, and bringing those voices into Canberra, which we did, was really powerful. So I think, you know, the biggest asset you have as an industry is all the people that you're serving. You know, if you can engage those people as patient advocates, I think that's where you have the most impact. Again, another example we did when we were doing our bill into medicinal cannabis, we toured the country and we were in a part of, I think, regional New South Wales. And when you see an 80-year-old farmer come in and talk about how his wife with MS had got great benefit from medicinal cannabis, you see the National Party MPs on that committee suddenly, again, they take notice.
Sure. Now, I'm not yet seeing a sea of hands, but I'm not giving up. So I'm sure next time I glance around the room, someone will have a hand up, or maybe that will stop saying test, which was testing my eyesight. But I want to chat about drug driving for a minute. It looks like we might finally be getting some movement in Victoria. And Drive Change campaigner David Heilpern, for example, has said basically the industry can't be a viable concern, you know, unless people can drive while using the medicine. How crucial is that reform to the long-term health of the industry?
Oh, it's critical. It's critical. I mean, look, there's a good deal of hypocrisy here. I used to be able to write a script for someone that would knock them out, and they could get into their vehicle and drive off. You might prescribe to write a script for somebody who's been on medicinal cannabis, a low dose of a THC product for a long period of time, or potentially a higher dose if they've been on it. We know that when it comes to impairment, there are far more dangerous substances that we can prescribe in our practice that will have a direct correlation to impairment. So, but it's critical. So I'm encouraged by what's going on here in Victoria. In fact, I just met our two new upper house cannabis MPs. And, you know, I think it's a great thing that they've put this on the agenda. The track record of the Victorian government when it comes to drug law reform hasn't been stellar, but I'm hoping that their recent election sends a really strong message and that we've got to do something about it.
I was going to ask you about that. Is it potentially a good barometer for legalised cannabis MPs in other states? And hopefully there will be, you know, maybe a couple more in a few weeks' time. That idea of kind of focusing on small but important goals that benefit the medical market rather than kind of chasing the recreational reform first.
Yes, I think that's right. I mean, again, just in case people are misunderstanding me, I would also say, before you vote for the cannabis parties, vote for the Greens, because we've always had this, but that's a gratuitous advertisement. No, look, if you look at what's happened internationally, both those things have often happened simultaneously, and I think they're mutually reinforcing. So often people describe what's going on within the campaign to legalise adult use cannabis as a potentially undermining the medicinal cannabis market. I don't think that's true. I think both those things can happen together. I think it's really important that we do focus, though, you know, the approach I took was very much, while we did some work around adult use cannabis, we wanted to see a model for the regulation of medicinal cannabis as our key objective. And we felt we had the best chance of success doing that because we just know there are so many people who are currently using it illicitly. So, yes, small gains. You know, often mostly politics is boring incremental change. Occasionally you have a breakthrough, but you're working with pretty powerful institutions and entrenched opposition, and you've got to pick your wins. So I think it's a really sensible thing that the two cannabis MPs have done. I think it's a really sensible thing, and I think that if we do get a sensible change here, it might prove to be a bit of a template elsewhere.
Sure. Okay, thank you. I want to sort of move on to we've got a hand. Brilliant, you get a prize. I haven't decided what the prize is yet, but when I do. If you could just wait for the microphone and just tell us who you are and where you're from, please.
My name is Chris Gilmore. I'm from the Commonwealth Bank in our healthcare team. I just have a question in relation to the driving. What are the technologies that exist that actually test for impairment in other countries? You know, in Tasmania, what is it?
Well, you're probably better off asking a technical expert that question. But what I can say is we know that there's no strong correlation between cannabis consumption, particularly in the context in which we're discussing, and impairment. So somebody who's been prescribed cannabis for a long period of time and they've been stable, there's not a correlation between them being able to drive a vehicle and having the presence of THC in their bloodstream. And that's the big challenge here. We know that we've got a biochemical or a marker for alcohol, which is correlated to impairment. Not as neatly as perhaps some might like, but it's still a reasonable proxy. Unfortunately, with THC, we don't have that. And so the challenge is, but I'd say the same around prescribing powerful opiates and benzodiazepines. So they're two drugs that are prescribed where there is a correlation, a much clearer one, between impairment and consumption. And we leave that decision up to a conversation between the treating doctor and the patient. And we make sure that we provide the right advice, that we give people education about the effects of these drugs, and then we entrust that patient to make the right decisions. And there hasn't been an outcry in the community, as far as I can tell, around other prescribed substances. So it feels to me like a bit of a double standard, particularly around a substance for which there is much less stronger evidence. So without probably going into more detail around that, I reckon, it's probably a technical question, and I don't think there is a clear answer, otherwise we'd do it and do it very quickly. I think a lot of and this is just me musing, I think a lot of the opposition is that people fear that the adult use market, it gives them a free kick. And I think for a lot of people, the drug driving laws are really a backdoor way of enforcing prohibition of adult use cannabis. Really, I think that's what sits underneath most of it. If we're taking a hard-headed, evidence-based approach to the effects of cannabis on driving, we'd just be focusing on other substances well before we're focusing on cannabis.
Now, I'm going to take one question from the screen on drug driving, and then I want to move on. It's from Peter Crock, who really should be having a microphone in his hand at this point and asking his own question, but I'm going to let it go in the interest of time. So how do we move the dialogue with police as one of the clear roadblocks to driving reform?
Who knows? I wish I could, if I could answer that question, I'd probably still be in politics. I think, it's a tough gig, and there are direct implications on what it means for policing. My experience, and this is a generalisation, and I'm aware of that, but my experience has been when it comes to drug policy, any reforms that necessarily mean a reduction in resources directed towards policing are generally objected to. So I think the challenge here is, the impact of some of this means that we're diverting some of the resourcing for policing to other areas, and I think that goes a long way to explaining why we are where we are. There are other things that we can do. Again, the education piece is really important. we've got to do everything we can to try and ensure it's not just GPs, but other sections of the community who understand the benefits and some of the regulatory issues that come up as a result of that. Drug driving is a classic example, but I wish I had a better answer. I mean, it's been a consistent problem when it comes to drug law reform, that often the police, it depends a bit on who happens to have the reins at the time, but the police and often the police union are implacably opposed. And I think partly because it speaks to some of the base, to be leading the police associations, a vote of the membership there, and it might be an issue that resonates with some of the membership. So what do you do there? Well, again, it's another education piece. How do we educate young policemen coming through about the potential benefits of cannabis and some of the issues around other drug policy?
Okay, that's great. Thank you. I'm just going to take a quick question from Lucy, I think. Oh, Lee.
Yeah. Yeah, thanks. And it goes to my earlier answer, Lucy, that's right.
Okay, all right, I'm going to move on from drug driving. I want to talk a little bit about industry reputation and maybe the responsibility that all of us in this room have in terms of not just politicians, but GPs, patients. You know, there's been some, TGA breaches recently, the advertising regulations. Some of those stories have actually got into the mainstream press. What kind of impact do you think that has in the corridors of power, if any?
Not a good one. I mean, and this is the challenge with a new industry where there are so many, there's so much entrenched sort of opposition, although obviously that's changing, but goes to that point earlier about the industry really needing to hold itself to the highest possible standard. What it does do is it gives those people who are sceptical reinforcement. It reinforces their position. And I think, the challenge really for the industry now is, as things have moved and changed, as the regulatory environment's changed, as the industry grows, and this is true of every industry, there are going to be people, there are going to be unscrupulous operators, people who come in who push the boundaries. And the advertising stuff was, I think, a real own goal. But having said that, did I hear correctly, though, none of the people involved were members of MCIA, which I think's a good thing. I think it's really important for the industry body to ensure that there are consequences, certainly for people who are involved with the association. But it's really critical that the industry, deals with people who are pushing boundaries in a way that really undermines all the great work that so many other people are doing. I think it's something that the industry's got to be very, very aware of.
So just to turn that round a little bit, what's the TGA's responsibility in that? Because you've got, as you say, there are companies who are spending a lot of time and money on research, which is ultimately going to be for the benefit of the whole industry.
Yeah.
You've got other companies who are spending that time and effort trying to, let's say, see what they can get away with, so to speak. Should the TGA be doing more about the latter on behalf of the former?
So you mean, should they be going harder against some of the rogue operators? I think so, although they went pretty hard recently. So,
But it's, I mean, some of it's like, you know, it's like finding a Premier League footballer, isn't it? I mean,
yeah,
you know,
sure. There's always more you can do. There's always more that they can do. I think the TGA will operate within this. Look, they're a technical, bureaucratic organisation that has a particular role, and they're going to operate within the purview of the role that they have. So I really don't think it's as much a question for the TGA as it is for other orgs, and particularly, you know, industry. I think it's really important that industries takes a very clear line on that. I think one of the other areas that I've got some concern about is that sort of vertical integration, where you come in and see someone and
yeah, the lack of transparency.
yeah, just that whole thing of you come in and you don't know that there's a relationship between your prescriber and, you know, the product. In fact, and I don't think it's the case now, but certainly when in the early days, you know, as a prescriber, the only way you really could do it at a practical level was to have some sort of sponsorship with one of the companies. And that's hugely dangerous territory. Like people would be outraged if they knew that their doctor was on the, you know, payroll of, I don't know, GlaxoSmithKline, and they're only going to prescribe you one sort of medication. I think that the industry needs to understand that it's the same, you know, the same problem applies to the industry. And it's a danger for doctors as well. So this is the argument I've made to the College of General Practice is part of the reason the college needs to get in there and ensure that there's independent training and accreditation, and that we ensure that there's more transparency and that they take a bigger role in this, is because at some point the penny's going to drop and people are going to say, well, how is it that there's this link between who's prescribing and what they're prescribing? I mean, that's been a very, very clear line in medicine more generally, and I think it's got to be a clear line in medicinal cannabis.
Okay, thank you. We have got a question. Can we get a mic to Steve at the front there, please?
Hi, Steve from Cannabis. Just on this issue of reputation, and with your GP hat on again, Richard, what's your view of telehealth in relation to prescribing medicinal cannabis? I mean, there's of course been suggestion that it's not the best way to manage patient care. So just wondering what your view of that is telehealth in relation to medicinal cannabis.
So I think one of the dangers here is we sort of hive off medicinal cannabis in terms of the expectations, the doctor-patient relationship, and we say that's got to be managed differently. If telehealth is a reasonable vehicle through which to deliver healthcare more generally, then it should be assumed that it's a reasonable vehicle to deliver healthcare when it comes to prescribing medicinal cannabis. With the caveat that, and this is where I think the danger is, you know, I think some of the more entrepreneurial practices can take advantage of telehealth in a way that perhaps they might not do in other areas, and that it risks not providing the appropriate clinical oversight that's necessary. I mean, in fact, I had a conversation with someone about this earlier. I think, you know, one of the benefits of medicinal cannabis, as with many other, you know, drugs for which people are seeking help, is in the therapeutic relationship with the practitioner. So, you know, you might have someone who's been using illicitly forever, might help them sleep, might help them with their anxiety. Well, having that therapeutic relationship allows the doctor to engage with their patient and actually try and unpack what's going on. So if telehealth provides an opportunity to have those conversations, that's a good thing. If telehealth has been set up in a way to just maximise revenue and churn, which again exists in other, it's not just unique to medicinal cannabis, then that potentially is limiting the effectiveness of it. So I'd probably say yes, but we've got to be really careful.
Right, we're sort of getting into the danger zone, but I'm going to just take one more question from just behind Steve there. But can I kind of limit you to, I'm going to give you a minute to answer this question, whatever it is.
Sorry, it's just a...
It's on, I think.
Okay.
Yeah.
Ian Housego, as an ex-GP myself, I just want to stand up for GPs as a rural practitioner and say that orthopaedic surgeons who charge 50 to 100 people who attend the fracture clinic in a public setting don't get charged for a fraud, whereas GPs have very recently been in the spotlight. I want to raise this because I think as a previously authorised prescriber myself, the biggest issue we have, especially in rural environments, is an understanding amongst our specialist colleagues. And until you as a group, as an organisation, until all of us can come to terms with the psychiatrists and the chronic pain specialists, the anaesthetists, Dr. Di Natale, I would ask your comments on this because I've been crucified on many occasions. In medicine, it's well known, GPs, the reason a GP had a complication is because we didn't refer. Yeah. The reason a specialist had a complication was because it was a known risk of the procedure. This is the big thing, in my opinion, facing cannabis.
Yeah. Oh, it's definitely an issue, no question. I've focused a lot on GPs because it's for the vast majority of patients, it's going to be the opportunity in which to have a conversation around getting access to medicinal cannabis. So, I think that if we don't address access issues through general practice, then none of the other stuff matters. But if we do that, we've also got to do what you're describing. And I agree. I think that there have been some huge obstacles with some of the particular professional bodies. I think you mentioned a couple of them, and their attitudes towards it. And I think there's a lot of work that has to happen there, no question. And then, look, we could spend forever talking about the relative value of the services that GPs provide and some specialists provide and how well remunerated they are relative to each other, but there's probably a conversation for another day.
Right, so we are technically out of time. I'm just going to look at Rosemary and say, have I got time for one or two more questions? One. Oh, one. Is that two? No, one.
Two.
Oh, two. I'm allowed two. I'm being greedy. Okay. So you've been involved in the medicinal cannabis movement since before legalisation, and back then, kind of Plan A was for an independent regulator. Is that still your preferred option, or do we kind of live with what we've got and try to improve it?
Well, I'd say yes and yes. I don't think it's an or question. So it's still my preferred model. I mean, when this all started, there was no regulatory framework, and our preferred framework based on what was happening internationally and based on the fact that cannabis is very unique in terms of the way it's the pathway into being approved for medical use. So, there are issues, the traditional pharmaceutical pathway where you spend years in R&D, get a patent, bring a wad of evidence through, get it approved and get it listed on the PBS. It just doesn't work for cannabis for all sorts of reasons. I mean, it's very hard to patent plant medicines. Just that model doesn't work. And so our view was to do what other jurisdictions had done, and it's still my preferred option. And if I was the Prime Minister tomorrow, I'd implement a new regulatory framework. And that would be for an independent regulator made up of people with specific expertise to focus on medicinal cannabis and to make sure there's a pathway for entry. However, it's not the world we live in, and the then Liberal government took a different decision and, in my view, tried to put a round peg into a square hole, or square peg into a round hole. I think it's the other way around. And so we're left with this sort of framework where, you've got this pathway that was reserved for a very small number of unapproved products for people who were, had terminal illnesses, and now suddenly we've had medicinal cannabis sort of become the sort of dominant drug being provided through that pathway, a pathway that was never designed for that purpose. My sense is that there's no sign of the current government wanting to change tact on that. So I think what we do have to do is make the best of a bad situation, and I think we've already seen some changes. There've been improvements. Again, when I left Parliament, it was very, very difficult to find a GP who prescribed and for those GPs who did prescribe, it was just very onerous, lots of red tape, etc., etc. So you had to be really committed. I think it's a bit easier now, not as easy as it needs to be, so we've got to keep working on improving it.
Okay, and last question, because I'm well and truly over time now. If there was one thing that people should take from this conversation when they're back at their desks on Thursday, what virtual desk, whatever it is, what would you want them to take from this chat?
That's a very big question. I think I'm going to not say one thing.
Okay.
I'll
allow you to.
I'll say one thing in terms of advocacy. I think advocacy is really important, and I think in terms of how you advocate, I'll just reinforce that earlier point. Patient advocates are the most powerful advocates you have. You're serving a community of probably millions of people, as far as we know, who could get potential benefit from medicinal cannabis. Many, many thousands of people who are already doing so illicitly. And it's very important for people to hear their stories. Again, I look at some of the people who brought this, Helen, for example, and the stories that they did when, just to shed light on the people who are doing this and the circumstances in which they're doing it. I think that's probably the most powerful thing that we can do to try and change politicians' minds. Okay,
Brilliant. Well, thank you very much. Before we thank Richard, the next session is Emerging Researchers Showcase, and that follows straight after this. So please stick around for that. Here comes the blatant plug. Don't forget to get your entries in for the inaugural Cannabis Awards. If you don't know what they are, come and talk to me. And finally, please thank Richard.